Bismillah ar-Rahman ar-Rahim. I'd like to join you today with a nice ECG trick. As you see this ECG, this young gentleman is an 18-year-old man who presented by recurrent palpitation, and his ECG was like this, with normal echo, no family history of any similar cases. Actually, in the clinic, one of the team diagnosed this as anteroseptal accessory pathway, and when explaining to the family of the risk of heart block, they preferred to do it with 3D mapping. Actually, this is this tachycardia documented, and this tachycardia, as we can see, it is narrow complex supraventricular tachycardia. This morning, when we were revising the case before entrance admission to the cath lab, we compared both ECGs. As you can see in these ECGs, AVL shows a negative delta. And the pretty of these ECGs are that they are together. Look at V1 in the resting ECG, there was an R wave. And look at the QRS complex all through the chest lead from V1 to V6, the minimal pre-excitation. We compared this ECG to the ECG of the supraventricular tachycardia. And if you look at AVL, the negativity of the delta wave in AVL became positive. And the same QRS complex in the chest leads the same like in pre-excitation. So this morning we were thinking, this is not anteroseptal accessory pathway. This could be a left lateral accessory pathway far away, so that the pre-excitation is not seen, and this is seen in young age because of the enhanced AV nodal conduction. So we changed the plan. We said we are not going to do it 3D, although we have everything ready, but we are going to do the basic EP study in the beginning to see, with the suspicion that it might be a left lateral accessory pathway. We'll go to the EP. Here, يلا جون ورينا الريستنج ECG, the intracardiac. هات من الأول. During we replaced the CS catheter, the capular catheter, from the inferior vena cava, and this is the resting ECG. Here we concentrated on AVL. Where is AVL? This is negative delta. Okay, and V1, there is an R wave in V1. This does not show like this in anteroseptal. This is why I said we'll start by EP study. يلا جون هات EGM. طبعا placing the catheters. He went into the tachycardia. Very good. So he is, as we saw in this in his clinical tachycardia. We placed the CS catheter before we placed the HIS, and you can see this eccentric activation. So this is a left lateral access pathway. ورينا بقى يا جون لما التاكيكارديا وقفت, and then the tachycardia stopped. بس قبل ما نخش بالابليشن, before we introduce the ablation catheter. And we saw that the pre-excitation is very well seen at CS1 and 2. So this is a left lateral accessory pathway. We did transeptal. Alfy did the transeptal. We'll show you on the fluoro. And we started to map on the left mitral annulus on the lateral position, and we induced the tachycardia, of course. We did V pacing also from the right ventricle. We were looking for the very good signal. This V pacing showed us that the retrograde here is far away. This is not the site. We did not ablate here. We looked at this signal and we saw that there might be a potential. We were very keen not to, we did pacing from the CS5 and 6, but when we did pacing, the catheter moved and we could not see a good V signal. This means that when you pace, it is pushed to the atrium. Then the tachycardia came, and we mapped during the tachycardia. Here, فين الحتة المابينج tachycardia? Okay, we mapped during tachycardia. We saw this VA time is very short compared to CS1 and 2 and 3, 4. And you can look that. You can see that the VA time on 1, 2, 3, 4. Actually, 3, 4 is better than 1 and 2. Can you increase the size gain بتاع 3 و 4 لو سمحت يا جون؟ أيوه ده كمان. Yeah. So Alfy was mapping the annulus أيوة. Yeah, during the tachycardia, yes. Aha. Ablation here, you can see that immediately with the first ablation point, there is VA kit and normalization of the ECG with complete separation underlying right bundle. Right bundle came because we were pushing the His catheter into the right ventricle. Then immediately the access pathway came back in the antiplatelet direction. We kept mapping. This is premature beat. I don't care about it. Until we got very, very good signal. Yeah, look at this. If we increase the size more of the ablation 1 and 2.
Please.
Yep.
Can you give before ablation?
Yeah. So look, Islimin V to delta. Now we have a right bundle, so the more pre-excitation will be on the left side. This is okay. It is 23, but it's very good compared to also CS12.
Ablation.
Yeah. Ablation here immediately, and we gave 50 watt. We gave 2 minutes 50 watt, and يعني look ممكن تقلل السرعة. The same here, pre-excitation normal with this right bundle. We should have AVL in the monitoring because that was a key. Now we are in the waiting period. We can look at the live screen. We pace now the His, which is in the right ventricle, and you can see VA dissociation. We noticed that during V pacing that there was no fusion, so there was pure retrograde through the accessory pathway. We are here at clock. We have to wait for 15 more minutes كده تقريبا, and that was a nice case. We'll show you the fluoro picture. يلا هات fluoro. This is the transeptal puncture guided by the His catheter. This is the LAO view of the transeptal. We use contrast, and sometimes we use cautery, and we push the contrast through the needle in order to make sure that you are in the left atrium. This is the ablation catheter with the sheath in the left side, and you can see we are directed to the CS 3 and 4. This is during mapping again. This is the RU view. It's more to the ventricular side than on the annular side, which is okay if you get this good contact, good sight, and that's all. Thank you very much.